Hi, good morning to all, and thank you for being here. My name is Mara Quintero, and I work for the World Federation of Hemophilia. And now I will be with you, our Medical and Humanitarian Aid Director, Dr. Asad Afar.
Thank you, Mara, and good morning, good afternoon, good evening to all of our friends attending this webinar today. We're quite pleased to have this webinar today because it's like a new era that the Department of Humanitarian Aid and Medical Education is now approaching. We are going to cover in the future more topics related to rare bleeding disorders, including the fibrinogen disorders. And for today's webinars, we are very fortunate because we are partnering with a very energetic, great group that deals with fibrinogen disorders, headed by an old friend who I worked with for the last 24 years, Dr. Philippe Dumerlos from Geneva, and Dr. Alessandro Cassini, also from the Hemophilia Treatment Center in Geneva. So I'm not going to take a lot of your time. I'm just going to give this back to Alessandro and Philip in order to lead this important webinar of today.
Well, welcome to this webinar on fibrinogen disorder. And as said by Asad, this is the first webinar on fibrinogen disorder, and we are very happy to do that. I thank the World Federation of Hemophilia for the support in this organization. So, as you know, there are several fibrinogen disorders. Today we discuss mainly on high fibrinogenemia, the most severe of fibrinogen disorder, and we will address some topics, including diagnosis, clinical symptoms, treatment option, and women's health. Questions that have been suggested by patients with fibrinogen disorders. Before to start, I would like to give a few words on our organization. The International Fibrinogen Physicians and Patient Association, composed by patients and by physicians experts in the fibrinogen field from Egypt, US, Switzerland, India, Italy, and Switzerland. The aim of our group is to share knowledge on fibrinogen disorder between patient and healthcare professionals and to promote the research and the networking of this very rare disease. Today we will have several speakers, two patients, Johanna Baquero from New York, US, and Christina Bozel from Amsterdam, the Netherlands. They will share their experience of this very rare disease, and they will introduce the other speakers that are Maggie Abdelwahab from El Cairo in Egypt. She will speak on the diagnosis of fibrinogen disorder. Sushitra Sharia from New York, US. She will speak on the clinical features of fibrinogen disorder. Philippe Dumerlos from Geneva in Switzerland. He will speak on the management of fibrinogen disorders. And Cristina Santoro from Rome, Italy, and she will address the women issues in fibrinogen disorder. So this is the agenda of this webinar. We will have 4 presentations. The first is what are fibrinogen disorders and how is it acquired. The second is what are the signs and the symptoms of fibrinogen disorders. And finally, we will discuss about the fibrinogen disorder treatment and what are the specific issues for women and girls. Before to begin, I would like to remember some practical details of this webinar. All the questions will be answered at the end of the presentation. However, feel free to write questions in the chat throughout the presentation. You can write questions in French, in English, in Spain, and in Italian. So let's start with the first presentation. What are fibrinogen disorders and how is it acquired? With the introduction from Joanna.
So hello, everyone. My name is Joanna Baquero, and I'm going to walk you briefly through the beginning of having afibrinogenemia. I was born in 1997 in Bogota, Colombia, in South America. I am the youngest of 3. My oldest brother also has afibrinogenemia. When my genotype was tested in Switzerland, it was found to be homozygous for the causative mutation. This is a single base insertion in the FGA gene. The way that I was diagnosed is the first symptom that I had was my umbilical cord did not heal. So that is the way in which the hematologist at the time knew that I had a bleeding disorder. In the rest of my family, I have a history of heavy bleeding from my father's side, but no real diagnosis to determine that there was any other real bleeding disorder at that time. So I'll pass it on to Christina.
Yes, hello everybody. Also from my side, I was born in 1995 in Austria. Within my family, there was no known family history of bleeding disorders. Also, my DNA was sent to Geneva, to Switzerland, and they found 2 mutations in the FGA gene. One of them is relatively common in Europe. How they found out that I had fibrinogenemia was quite complicated because I had a very heavy bleeding from the umbilical cord. And in order to stop the bleeding, they gave me a blood transfusion, but they actually thought because of the heavy bleeding, my bleeding, it didn't work anymore, but in the end, it didn't work from the beginning and the blood transfusion stopped it. And in my family, there are a history of bleedings and also thrombosis, and only my mom's side has a reduced fibrinogen that was only found after I was diagnosed. And I will pass along to the doctor's side of things.
Okay, hello everyone. I'm really glad to share in this webinar, which addresses some of the unmet needs of the fibrinogen disorders community. Thanks, Alessandra, for the kind introduction, and thank you so much, Joanna and Christina, for sharing your stories. Actually, I'm quite proud of our eldest patient in the clinic, who is currently a 19-year-old who has just joined university, first year of University of Commerce, in spite of having a very severe phenotype like that of Joanna's and Christina, and having so many challenges. Now, the thing is, when the lab diagnosis comes with a fibrinogen disorder, that's the discussion that we usually have with the patient if he's an adult, and with the parent or the caregiver if he's a child. So we start by defining what fibrinogen is. Fibrinogen is a protein involved in wound healing, as well as helping in stopping the bleeding. Now, the thing is, when a child or an adult gets injured, a process takes place to stop the bleeding. It's composed of 2 phases. The second phase includes coagulation factors, 13 of them. Number 1 is fibrinogen. It's usually inactive. When it becomes activated to perform its action, it forms a fibrin mesh. And so that stops bleeding and helps in wound healing. So no fibrinogen, no fibrin. And so patients develop bleeding. And paradoxically, they can have unusual blood clots or both. Dr. Acharya is going to discuss that later. Next, please. Okay, the fibrinogen disorders are due to an abnormality in the amount or the function of circulating fibrinogen, or both. And they are usually divided into afibrinogenemia, complete absence of fibrinogen, hypofibrinogenemia, reduced levels of circulating fibrinogen, usually less than 150 milligrams per deciliter. The normal is 200 to 400. Dysfibrinogenemia, abnormal function of fibrinogen. That's to say the fibrinogen doesn't do what it's supposed to do. Or rarely, hypodysfibrinogenemia, a low fibrinogen and abnormal function of fibrinogen. That takes us to the next slide. Next, please. Okay, so are fibrinogen disorders common? They're actually rare, like Joanna pointed in her slides, actually 1 in a million. However, we are currently noticing an increase in the number. If we go over the last surveys of the World Federation of Hemophilia, the one that was in 2014 from 106 countries included 1,712 patients. However, there was a significant increase over the past 8 years, and we are now confronted with around 5,000 patients from 125 countries. Actually, here, this is Egypt, so you can see the pyramid. So now actually we have also an increase in our Egyptian cohort. So what do we attribute this increase to? Actually, it's due to 3 factors or multifactorial. Increased awareness due to better diagnosis and increase in the number of populations, as well as an increase of the knowledge of underlying mutations. Also, the COVID pandemic has really contributed to that increase, as we see a surge here because labs have become more oriented with accurate estimation of fibrinogen. Next slide, please. Okay, so how do we get fibrinogen disorders? This is a very important question that we usually confront. Well, they are inherited. By that, we mean they are passed from one generation to the next through the genes of one's parents. One gets to have a copy of gene from each parent. Genes are responsible for characteristics as the eye color, and in our case, the probability of having a fibrinogen disorder. The pattern of inheritance is either autosomal recessive or autosomal dominant. Now, what do we mean by that? We can explain that more by looking at this diagram or cartoon. Hypo and afibrinogenemia that we are going to focus on in this webinar, as Alessandra pointed earlier, are usually autosomal recessive. So what do we mean by that? So we have 2 carrier parents. The unaffected gene is usually the dark blue, and the affected gene is the light blue. Carriers are usually asymptomatic, but they pass the genes on to their children. So what do we get here? A 25% probability of having an unaffected child, a 50% probability of having a carrier child like their parent, and a 25% probability of having a child with afibrinogenemia. Now, the dysfibrinogenemia is usually inherited as autosomal dominant. Now, as the name implies, it's a dominant gene. So we have one parent with the muted gene and the other unaffected parent. So what do we get here? A 50% probability of having an affected child with the muted gene and a 50% probability of having an unaffected child. Next, please. So when do we test for fibrinogen disorders and how do we diagnose them? If a person have some bleeding symptoms, we need to score that to be sure that we really need to do the tests. So we do that using the BAT or the bleeding assessment tool. If positive, 4 or more, we would do the routine blood clotting tests, the PT, the prothrombin time, and the partial thromboplastin time. If both are prolonged, especially with early umbilical bleeding, we would proceed to do the fibrinogen assay, because that's probably a fibrinogen disorder. We have 2 methods. We usually use the Klaus method, but there is also a very good method called the antigenic method. Now, we usually confirm the diagnosis by doing the genetic testing. Genetic testing is also important to screen other family members, as this is an inherited disorder, and also to screen mom when she is pregnant again. What we call prenatal diagnosis. What are these 2 sets? 2 tests at the side. This is TT or thrombin time and rictulase time. We don't have to do them, but they can help in diagnosis of fibrinogen disorders. Thank you.
Thank you, Maggie. Let's move on the second presentation of this webinar. What are the signs and the symptoms of fibrinogen disorder, with the introduction from the patient and then the discussion from Sushita Acharya.
Okay, so I'm going to walk you through my life history, timeline of my life, of the type of signs and symptoms that I've experienced with afibrinogenemia. So growing up in 1977, 1979, the first 7 years of my life was about having a lot of leg pains. I had a lot of bruises due to trauma, and of course bleeding in the gums, especially when I went to the dentist. So I normally needed treatment after going to the dentist. In 1990, I experienced my first menstrual period when I was 13. It was a very heavy bleed at the time. To the point that I got anemic after only 2 periods. So at that time, it was decided with my doctor and gynecologist that I would start birth control pills nonstop. A year later, being a kid as I was when I was 14, I decided to climb a tree, and I fell from the tree, which caused my first intracranial bleed. And then 6 years later, I had my second intracranial bleed, which was a subdural hematoma. And the way to recognize at that time, I was already being very familiar with the feelings of having a headache, feeling dizziness, feeling loss of balance. And that was something that I started to identify in the second intracranial bleed. Fast forward 2 years later, while exercising, I had an abdominal intramuscular bleed. And in 2000, after hitting my hand, I had a compartment syndrome. It was basically, there was pressure buildup from internal bleeding in my hand, and therefore I had that compartment syndrome. In 2001, after taking a flight to San Francisco from Bogota, and then shortly after a flight to LA, so two flights, because of the air pressure in the airplane, that was the cause that, at least that we concluded, caused my third intracranial bleed, which was a right occipital and cerebral bleed. And then at the end of the year, of that same year, I had a different type of bleed, but also in my brain, and that was more of a, it caused some altercation, I would say, with my peripheral visual field, which then was a permanent loss that I had. And then in 2003, it was the first truly spontaneous intracranial bleed that I had. This was not caused by any trauma. I wasn't going on an airplane, nothing like that. It was truly spontaneous. So at that time, while working with my hematologist, we defined that I needed to go on prophylaxis for 1 year. That 1 year of prophylaxis actually helped me for the next 6 years, until in 2008, I moved to the US, and in 2009, I had my 6th intracranial bleed after having a workout in the gym. So I had a subdural hematoma with a small rightward midline shift. In 2009, while I was still in the hospital, 6 days after being in the hospital and achieving fibrinogen levels between 100 and 140, I had a rebleed. So the volume of the hemorrhage increased. And so at that point, it was in New York Presbyterian with my doctors there that we decided, I needed to go on prophylaxis nonstop. This was a hard reality for me to accept, but I still said, okay, I want to do prophylaxis, but I want to remain independent. So because I have very poor veins, we said, okay, I need to have a central venous access. So in 2011, I had a PICC line placed. And the PICC line placed was great for a solution, but unfortunately I had a blood clot at that time. So I was treated for a blood clot, and we said maybe the PICC line is not the best idea. Let's go with the portacat. So the portacat was placed, but 3 months later I had a pulmonary embolism. So I was treated for the PE in the hospital, and it was resolved. 2 years later, I was diagnosed with breast cancer, and breast cancer has nothing to do with afibrinogenemia. The reason why I bring it up is because to me, it was a realization that at the end of the day, I am also a human being that is not excluded for any other sicknesses that anybody else can have. So I'm happy to report that since 2013 and even since 2009, I've had no bleeds. I continue to be in prophylaxis twice a week, and I haven't had any clots. I continue to do prophylaxis, and that's helped me healthy. So with this, I'm going to pass it on to Dr. Acharya to talk about symptoms and signs.
Hello, everyone, and thank you for joining this webinar. Joanna and Christina are lived, experienced experts. Thank you for sharing your stories and your journey. What an amazing journey, Joanna. I can't even imagine, but you look wonderful. And that's the message, I think, for all our patients, that we need to work on this. We've come a long way in understanding what fibrinogen disorders are. And currently we classify them into these 4 subgroups: afibrinogenemia, as Dr. Abdul Wahab already referred to, where you make essentially minimal fibrinogen protein or none; hypofibrinogenemia, where you make some amount, but it's inadequate; with dysfibrinogenemia, you make the protein in normal amounts, but it's not functional. And in hypodysfibrinogenemia, as the name suggests, the amount of protein made is inadequate and it's not functional. Next slide, please. So the severe fibrinogen disorders can present as early as the newborn period, as we've heard from both our lived experienced experts here, with umbilical cord bleeding, can present with a muscle hematoma after vitamin K, which is routinely administered to all newborns, soft tissue hematomas from heel sticks, which is done for newborn screening, at least in the United States and other countries. And intracranial hemorrhage can also occur in the newborn period, especially if this is a vacuum or a forceps-assisted delivery in an unsuspected newborn. So that's something always to kind of keep in mind. As the newborn transitions to being an infant, muscle hematomas can occur from immunizations. You can develop soft tissue hematomas from the trauma of like carriers or diapers, and oral bleeding from tooth eruption. As the infant transitions to a toddler, where the toddler starts now ambulating, walking, running, that's when you see joint and muscle bleeds. And intracranial bleeds can occur anytime during this time frame and when you're older, as described by Joanna, usually with trauma, but can be spontaneous. Next slide, please. And so the most common symptoms, though, of these fibrinogen disorders, and especially with the afibrinogenemia patients, is mucocutaneous bleeding. As you can see here, you can have prolonged nosebleeds, oral bleeding, ecchymosis, bruising, umbilical cord bleeding. But there are also other rare complications that have been reported, such as spontaneous rupture of the spleen, developing bone cysts. There's also delayed wound healing, since fibrinogen is involved in the healing process. So that's something we always have to keep in mind when we attempt to make a diagnosis of these disorders. Next slide, please. The hypofibrinogenemia individuals usually present much later in life and typically could occur after surgery or after trauma with bleeding symptoms. On occasion, if screening tests are done prior to a procedure, an individual can be diagnosed just because of abnormal screening tests. And a lot of these individuals, when they become pregnant, they could undergo early and recurrent miscarriages. Half of the dysfibrinogenemia patients tend to be asymptomatic, or they can present with bleeding following surgery or trauma. And they are also predisposed to early and recurrent miscarriages and placental abruption. Next slide, please. Although we like to think about fibrinogen disorders as typically bleeding disorders, interestingly, there's also a paradoxical risk of developing thrombosis or blood clots, as Joanna described in her journey. And these tend to occur both in arteries as well as veins, and they tend to be recurrent. Next slide, please. So why do we see this variability in clinical symptoms? We do now understand that no two individuals with the same diagnosis actually can have similar symptoms. You can have really mild bleeding symptoms, or the other end of the spectrum when you can have pretty significant bleeding or thrombotic symptoms. And so a lot depends upon the intensity of activity that you're engaged in and the lifestyle that you lead. And this does not mean that you become a couch potato or live your life in a bubble, obviously, because exercise is important. I'm so happy that Joanna still continues to pursue her active life, which is really important because we do understand that exercise also decreases bleeding risk. I think, at least from the hemophilia population, we've learned a lot about that. And so when you do want to exercise, I think it's really important to meet up with your hematologist and come up with a treatment plan. Specifically, I would say prophylaxis early on, so that you can do whatever you like to do in life, because we all have, one life to live. And prophylaxis is really important, as will be discussed by Dr. Philippe very soon. I think what we do understand now is that the earlier the age at presentation, the bleeding severity tends to be a lot more. And also, if there is ongoing inflammation or there's inherited risk factors for developing blood clots, like some of you may have heard of factor V Leiden, a very common risk factor for blood clots, I think the predisposition to thrombosis tends to be higher in those individuals. And currently, the best predictors are personal and family history of bleeding or thrombosis or development of blood clots. Now, one thing I would like to say, there are, I'm sure, parents in the audience who want to understand. So I have a child now with a fibrinogen disorder, afibrinogenemia. Can he play sports? We just saw, Joanna has done everything that she can do to stay active. And so if you do want your child to play a sport, I think it's really important, again, to touch base with your hematologist, come up with a treatment plan, start prophylaxis as early as possible. But again, you have to think about how to do prophylaxis with, venous access devices such as portacats or PICC lines. And those are some of the things which really need to be addressed in a manner that's, doable for you and your family. And I would say typically we would encourage non-contact sports such as swimming, golf, tennis, and preferably not football, but other things can be modified. And so I would like to thank you for your attention.
Thank you very much, Sushita. Now the times for discuss about the management of fibrinogen disorders. Joanna and then Philippe de Melrose.
Okay, so in terms of the treatment that I've had, it's changed throughout the years. I started when I was born, I was treated with cryoprecipitates to treat trauma or the leg pains that I talked about on a needed basis. In 1994, I had after the spontaneous bleed, I had the hemocompletan, which was the fibrinogen concentrate at that time that we could access imported from Germany. I did that for a year. And then in 2009, I started Riostap, which is fibrinogen concentrate, as a nonstop prophylaxis. And I didn't know exactly the amount that I needed. So I did a pharmacokinetics test to define the frequency and the amount of fibrinogen that I needed. So after that, it was concluded that I needed to do it twice a week. And in 2011, as I mentioned before, I had a portacat placed on the chest wall to enable self-infusion. So I use a mirror to do my self-infusions. And I've been doing that since 2011. To date, I've had 3 ports placed. And today I continue to do infusions twice a week. And the only thing to counter the production of clots, I use enoxaparin to prevent the clots. I'll pass it on to Christina.
Yes, so for me, it's a bit different because I actually got prophylaxis from a very early age, which is not to say that it was an easy way, because in the beginning, we were told that prophylaxis is not an option, that I will have a very restricted life, that I won't play sports, that I can't travel, whatever. So my parents actually contacted other hospitals, other countries to see patients there, and we found some in Switzerland back then. And then we, together with my doctors, because I was there for once every week, and it also led so far that my parents carried me over cobblestones because they were so afraid that the stroller basically gave me intracranial bleedings, that they said this has to stop because I didn't move a lot. I had a helmet, I had knee protection, I had elbow protection, I had everything. And this was not the future that they envisioned for me. So then we managed to get prophylaxis with hemocompletan. And ever since then, I'm on prophylaxis, which changed a bit over the years, of course, with age and with weight and everything. My mom also learned to do it at home when we were in the year of 2000, which was also a very nice step, because then I could do it at home, watching TV, eating next to it, whatever. In 2005, because of my veins, I got a portacat placed, and I hated it because for me it was very sterile and I couldn't do a lot and I couldn't move a lot. So then we slowly reenacted the veins, and from then on it also got better because we did hand baths, we did arm baths, we also used the blow dryer to make the veins come out. So basically everything to make it easier. And in 2010, I decided it's time to go on a trip alone, or to go on a study trip to England. And I learned to self-infuse with 14 years old, which also gave me a lot of independence, because from then on I could just do it myself. And I've been doing it since then, ever since like that. And fast forward this year, I traveled to South America, much to the regret of my mom, who is in the audience, because 3 months traveling to South America doesn't sound like the best idea for somebody with such a rare disorder. I had an extra suitcase with all of the medicine in, with coolers, with a letter, whatever. It was very hard to carry, and my boyfriend had to carry it with me, but we both wanted to do it. In the end, I had the nicest infusion with a view of the ocean, so I think that is the most exotic place I think I will ever do an infusion. And what we do is that we try to have like a goal of being over 1 gram per liter, or over 100, to also, for example, if anything happens regarding operations or so, that there is an easy way in and to do it as quickly as possible. That's how we do it.
Next, Philippe de Morleau speaking. Welcome to the 127 participants, which is great, really. So concerning the treatment, as you can see, there are 3 circles on this slide. The first one, obviously, it's the clinical expertise, but that's completely linked to the patient's values and expectations. And I think that what Joanna was saying and what Christina were saying, it's important and to discuss for their own value and what they expect, especially when they do a travel in South America. And research is on the slide because most of the recommendations that we have are based on consensus. We lack big studies, and one of the reasons of our group is to join our efforts and to tackle some of the questions which are not well resolved till now. So next slide, please. So as you can see, there are mainly 2 things: fibrinogen concentrates, or in several countries where they are not available, cryoprecipitate or fresh frozen plasma. And you can see that we are in favor of fibrinogen concentrate due to the fact that you can measure the fibrinogen concentration, and there is only one thing, which is fibrinogen, and not other factors. The safety profile, since an activation of this fibrinogen concentrate is, I would say, almost perfect, is not anymore a concern. And clearly, it's easy to administrate. I mean, the low volume, and you can do that at home. So it changed the life of the patients. We put in orange, not in red, because we are perfectly conscious that in some countries there are not no possibility to get fibrinogen concentrate. So there are cryo, and some cryo are inactivated also, and fresh frozen plasma. But both are limitation. We put only 2 things, but the volume overload potentially, especially if you give fibrinogen frozen plasma, and the impossibility to do things at home when you have this kind of treatment, fresh frozen plasma or cryo. And you can get also some transfusion reactions. Next slide, please. So replacement, it's written efficient to prevent, not only to treat, but also to prevent and treat bleeding in case of surgery and acute bleeding. Clearly, I mean, when you replace a fibrinogen, it's for this kind of purpose. Prophylaxis, with what Joanna and Christina were saying, you realize that it's really, I mean, the way to reduce or almost eliminate potentially, if it's done on a good pharmacokinetics, at least life-threatening bleeding, but more than that. And there are some questions around bone pain, which is one of the complications potentially linked to fibrinogenemia. The key words for the presentation is individual treatment. I mean, as I said in the beginning, there is no real consensus. And often the patient knows better than the physician or healthcare professional what is important for him or for her. And we have to adapt that. And for example, as Joanna was saying, she did pharmacokinetics, and she saw that twice a week was necessary. So including the judicious use of central venous access, like Christina and like Joanna, education and emotional support, which are clearly important. And as we said just before, fibrinogen concentrate is not widely available, so you have to rely sometimes on cryo or on fresh frozen plasma. Next slide, please. For us, I mean, dealing with patients having a various kind of bleeding of hemostatic disorder, one, I would say, good thing is that the fibrinogen has a long half-life. And that means you are not obliged to give as often as sometimes in hemophilia or other disorder. We just were saying that it should be individualized, but there are some general ideas saying that for the prophylaxis, the fibrinogen level should be more than 0.5, and just so that for Christina it was 1, which is really great to have this trough level. I think it's really more than 0.5, and 1 is clearly better. For in case of acute bleeding surgery, I think it will be discussed concerning the woman else, but a peak fibrinogen more than 1.5 gram per liter is necessary. And we prefer to give more frequent infusion instead of big amount in once, because I mean, days of thrombosis probably linked with that. I mean, it could be one of the explanations why some patients got some thrombosis. Next slide. And I think it's the last slide concerning the thrombosis management. You saw the problem that Joanna was dealing with. So in case of severe fibrinogen deficiency, we have some possibility in case of thrombosis. If it's mainly arterial, it will be antiplatelet agents. And when it's either combined or especially venous thrombosis, like pulmonary embolism, we have the choice between direct oral anticoagulant, heparin, usually low-dose heparin, and vitamin K antagonist. Next slide. I think it's the last slide. Yes.
Yes.
Thank you.
Thank you very much, Philippe. Now we are going to the last presentation from two Christinas. Christina Roser will make the introduction, and then Christina Santoro will speak about issue for women and girls. Thank you.
So yeah, as I said before, I'm on prophylaxis 2 times a week, and to add, this was also established with a pharmacokinetic underzoeking. I'm now speaking Dutch. No, but you need with the testing in the hospital. And since I have that, I think until since I think 10 or even before, I've also had that before my first period, which then was very normal, and I never had a period that I would describe as abnormal. But then again, what is normal when you bleed and what not? But it's replicated the stories from my friends at least. So I'm also on anti-conception, and that is something that was proposed to me by my doctors, of course, for anti-conception reasons, but also because with the Cerazette that I take, it's estrogen-free, so it also reduces menstrual bleeding. So I haven't had a menstruation, I think, for quite a while, and I only get it when I don't take it. And for me, actually, it was very hard to find a gynecologist who has experience, because I mean, as all of you know, most of the times they say, "Ah, you're the first patient I ever met who has this disease," and actually they don't know that you actually don't like to hear that, but it is like that. And so I struggled to find a gynecologist. In the end, I stuck with the first one I had because I had a good relationship with her, and now that I moved countries, I will look there. And what you all probably, or what the women with us think about is pregnancy. And I had a very unfortunate experience with a doctor who told me, because I asked her, and I was 12, I think, by the age, and she told me, people like you don't have children. And back then I didn't want to be pregnant or whatever, but I wanted to have a future with children. And ever since then, I was like, okay, watch me. And I think I've read to this date every scientific paper on fibrinogenemia and pregnancy, I think. And I found out that it is possible. And I mean, we will see it from the other Christina coming up, that it's definitely possible. So I say in 2024, I'm not pregnant yet, but I will be, I mean, if it's genetically possible, whatever, and definitely not destined by my bleeding disorders, I will definitely be pregnant in the future. So Christina, this is your.
Thank you, Christina. So first of all, let me tell you how proud and happy I am to be part of this group, and how happy I am to see such a great participations in this webinar. We are talking about the control of menstrual bleeding, and as Christina was telling to us, the fibrinogen concentrate prophylaxis can control the menstrual bleeding. And in fact, there are some patients that, for example, infuse with fibrinogen concentrate just during their periods. Another possibility that we have to control the menstrual bleeding is the estrogen-free pills that can be very useful. Why we talk about estrogen-free pills? Because the estrogens can increase the thrombosis risk. So it is important to suggest a pills, to recommend the pills like this. As also Christina showed us before, it is very important to strictly collaborate with a gynecologist and in case also an obstetricians, because we as hematologists or internists, that we are the referral doctors for such rare disease or other rare diseases. It is our duty to have a collaboration and to send our patients to people that know something about the pathology, and to colleagues who are in contact with us. Thanks. The next. Okay, and talking about pregnancy and delivery, we so as a group very recently, and thanks especially to our president Alessandro Casini, who put a lot of efforts in all this work. We published this article about the management of pregnancy and delivery that is based on experts' opinion, because as Philippe just told us, we don't have a lot of evidences, studies about this rare disease. So we have a lot of expertise or experts' opinion. The next. About afibrinogenemia and also hypofibrinogenemia, when the hypofibrinogenemia is severe. First of all, it is important to provide the genetic counseling, and it's very important in case our patients are not on prophylaxis, to start a preconceptional fibrinogen replacement, because the fibrinogen is such a complex molecule, and it is very important also to maintain the pregnancy. So this is an important message to our patients, especially to afibrinogenemia patients and severe hypofibrinogenemia patients. Next, please. Then, when the pregnancy is started, it is important to frequently measure the fibrinogen levels, especially to maintain a trough fibrinogen level equal or more than 1 gram per liter throughout the whole pregnancy. In case of bleedings, for example, such as vaginal bleedings, then it is necessary to have a higher level of fibrinogen, such as 1.5, if it's possible, of course. And as regard the thromboprophylaxis, in this case, is the same for the general population, with the adjustment in the fibrinogen replacement depending on the bleeding phenotype of the patients or the previous obstetric history. Next. And when we arrive to the delivery, we need a higher levels like equal or more than 1.5 gram per liter, either for vaginal or cesarean section, and of course to use the neuraxial anesthesia to avoid spinal hematomas. Next, please. After the delivery, it is important to monitor the patient at least for 72 hours. It is important to administer the fibrinogen and tranexamic acid in case of postpartum bleeding. And for patients, for women who are under fibrinogen prophylaxis, we can consider the thromboprophylaxis at least until the discharge of the patient. Next, please. So after all these efforts, we can have a very beautiful child that in case of an afibrinogenemia, mom will not be an afibrinogenemia child, of course, because he will be heterozygous. But in case we suspect an afibrinogenemia child, we have to delay all the elective procedures until the diagnosis. I want just to tell you just a little thing for this fibrinogenemia women. In these cases, it depends on the levels also of the fibrinogen of the patient, but the preconceptional fibrinogen prophylaxis is not always recommended. So it depends on the different cases. And this is when we talk about this fibrinogenemia women. And I think that this is my last slide.
Thank you, Christina. We are reaching the end of the presentation, and before to start the answering to the questions, I would like to remind you that there is a patient's booklet that covers many of the topics that have been discussed in this webinar. The booklet is available on the website of the World Federation of Hemophilia, and also include some data on other fibrinogen disorder other than afibrinogenemia, including hypofibrinogenemia and dysfibrinogenemia. I invite you to have a look at this patient's booklet if you are interested. And also, I would like to extend my thanks to all the participants to this first webinar on fibrinogen disorder, but also to all patients and collaborators around the world that for many years are collaborating with us. I think that it's very important to share the knowledge between us and to promote the research and to have a networking around the world for such a rare disease. Thank you very much. And we now can start for the question. You can raise your hand if you have a question, and we will go through the question in the chat. I don't have access to the chats yet, but if there are some questions, other panelists can start to answer to the question. And in case, here is my email and the email of Joanna. You can contact us if you have additional questions that you don't have the time for today. Thank you.
Maybe I can start. I saw a question that was directed to Joanna and me, and so I do 2 times a week, and 1 time 2 gram and 1 time 3 gram. That only changed in a very minor way, because when I was younger and around also at the age of 8, I got like 2 times 2 grams a week. And maybe to add from the question of Linder, I mean, I'm not the doctor, but I know that, for example, in the Netherlands, there have been 2 women giving birth with fibrinogenemia, and they had a good outcome once they were properly treated. So that's what I know.
Yeah, I guess you're asking, so the answer to how many do I infuse? It's 2 grams every infusion, so that's 4 grams in a week. And I take enoxaparin, which is to prevent the blood clots. And one thing addressing another question that came in, which is I'm also allergic to Riostat. So I pre-treat with Benadryl or Claritin to prevent the allergy that I have of fibrinogen concentrate. But I guess if we go from the top, because I don't want to ignore the questions that came on earlier. So for the first one, I guess this is more for the doctors to say, they say, should I take a prophylaxis before a flight? Can a flight cause bleeding or diving too? I guess for me, because I had the experience of taking 2 flights and that was the let's say the hypotheses of why I was getting the intracranial bleed. I was treated with prophylaxis before taking a flight, but I guess I'll open it up to the doctors. What is your advice on that one?
Philippe, do you want to answer to this question of the treatment?
No, you can start, Alessandro. Go.
So I think that, yeah, we can suggest to have a prophylaxis before a flight. For the diving, this is a very complicated question. I know one patient with a fibrinogenemia, which is the president of the Swiss Hemophilia Association, which is a very, very fan of diving. And he make prophylaxis before each diving. So, but this is an open question for the moment. We can go on. There is some, yeah, okay. Why is there thrombosis when this is a bleeding disorder? What is the cause of the clots? I don't know who want to answer. Maybe Sushitra, you want to answer this question on the paradoxical thrombotic risk in fibrinogenemia?
Yeah, sure. I mean, I'm not sure it's proven, but there are hypotheses around why you get clots. So the dysfibrinogenemia population, there are certain genetic variants that increase your risk for thrombosis. And that's why I think it's really important, if possible, to get genetic testing so that when you are actually treating for a bleed in those who have a predisposition genetically to have a clot, it might make sense to treat for the bleed as well as give them prophylactic blood thinners, anticoagulation. It seems like in the afibrinogenemia patients, and I'm sure Alessandro and Philippe and others can pitch in, the way I kind of understand the reason for the clots is because when you have afibrinogenemia, the clot that you form is not a very resilient and strong clot. And obviously this clot is subjected to breakdown by the clot breakdown enzymes, which we call the fibrinolytic enzymes. And when you have a non-resilient clot, you do break down these small pieces of fibrin, which can then embolize and cause clots. So that's kind of my understanding of this, but I'm sure others can, pitch in.
Mara, if there are some participants raising hands, can you also tell us and we can answer to the question in case? If I go through the chat, there is a question.
I'm sorry, Alessandro. Yes, I let that person talk. It's Saad Bakar. Saad?
Yeah, Saad Bakar from Pakistan.
Yes, hi. Thank you guys for arranging this webinar. It's so informative. Can you hear me out?
Yes.
Okay. So I just wanted to know that being on prophylaxis, actually, we don't have any access to the treatment here in Pakistan for factor concentrates. So I usually get cryoprecipitates or fresh frozen plasmas. Plasmas were actually doing not so well with me because the volume overload was too crazy. So I shifted on to cryoprecipitates. So cryoprecipitates also cause me dizziness and doziness as well. And I cannot be on prophylaxis with that because I can't get it unnecessarily. If I get it, I remain very weak. My palpitations remain so high, and I stay in a very bad mood. So what do you suggest for that?
I think we can turn the microphone to Assad because it will be well to get some fibrinogen concentrates. But clearly your problem, Assad, is a transfusion reaction. It's a mixture of things. And I would not say the perfect solution would be, but if you can get fibrinogen concentrate, because it's a long run disease, I mean, it will really help you. And I said, I don't know what is availability in the World Federation of Hemophilia to get fibrinogen concentrates.
Well, in fact, Philippe, thank you for this question. And again, thanks for Saad for raising this point. We are trying hard because, the fibrinogen disorders is part of the rare bleeding disorders. And now we started to address this in the work of the World Federation, particularly in the humanitarian aid donation that we get. We are trying hard to get from our donors some concentrates for the fibrinogen. Sometimes we succeed, sometimes not. But once we succeed, we will gonna give it to our hemophilia societies, and hopefully the people in these countries will be able to get these concentrates. Now, I don't expect that from the beginning we are going to get concentrates that are available or sufficient for prophylactic treatment for the patients in developing countries, but at least there will be some for the on-demand if they need that. But we are working hard on that, in fact.
All right. Thank you so much. Thank you so much for answering.
Thank you. And Maggie, there is a question regarding the diagnosis. Why should we do different diagnosis for quantitative or quantitative fibrinogen disorder? Treatment is unique.
Can you please see the question again? Because I actually read it in the chat, but I couldn't understand what the person asking meant.
Yeah, I think to make the difference between quantitative or qualitative fibrinogen disorders.
Yeah, as long as the treatment is the same. So the person, I think, asking, why do we need to go in that way and just get the right diagnosis, as long as we are going to treat at the end the same?
Well, it's different because, for example, if you have a dysfibrinogenemia, you're more liable to thrombosis. That will take the upper hand. So you will keep a close eye, and if the patient develops an unusual blood clot or a thrombotic event. Of course, in all the fibrinogen disorders, like what was said by all the speakers, you can have bleeding and thrombosis. But with dysfibrinogenemia, it's usually the thrombotic phenotype that's taking the upper hand, and vice versa with the fibrinogenemia. So it's important to know what you're dealing with, to be able to have a management plan, because the management plan includes not only on-demand therapy or treatment during the active bleed, but also prophylaxis. So if you're going to put a patient, whether be it a child or adult, on prophylaxis, you have to know if they have a dysfibrinogenemia or a dysfunctional fibrinogen disorder or a quantitative fibrinogen disorder.
Thank you, Maggie. After there is a question regarding the hypersensitivity reaction on fibrinogen concentrate, maybe I can answer to this question. Indeed, as said by Philippe, one of the inconvenience of fibrinogen concentrate could be the allergic reaction that is quite common. You can take some antihistaminics or steroids before each injection.
And we sometimes used, sorry to interrupt, Alessandro, because sometimes we get patients having quite severe reactions. You can use steroids as well together with the antihistaminics, and they really help.
Also, I would like to add, if you are reacting to one product, I mean, if product is available, obviously, you could try to switch to another product. There are at least now 3 different fibrinogen concentrates that are available, because I've seen patients who react to one but may not react to another product. So that's also, you know, a possibility.
Yes, I certainly agree. Even with the locally manufactured products like the cryoprecipitates or the fibrinogen, sometimes when you use the locally manufactured ones, you get a reaction to one, but you don't get a reaction to the other.
That's true. Thank you. And there is one question about the emicizumab in fibrinogen disorder. Emicizumab is a bispecific antibody that we can use for hemophilia. The problem is that in the emicizumab, we increase the thrombin generation. That means that we increase the thrombin that will activate the fibrinogen in fibrin, but the problem in fibrinogen disorder is on fibrinogen, so we cannot use emicizumab at all, unfortunately, for the moment. And then there is a question for a bleeding patient. Every 10 kilograms, we usually give 2 units of cryoprecipitate. What's your thought? Maggie, Sushitra, if you want to answer, because in Europe, we don't have cryoprecipitate.
If I understand the question correctly, it's the dosing of the cryoprecipitate, right?
Yeah.
Yeah. Okay. So again, we don't use it specifically for fibrinogen disorders, but there are other situations, for example, in DIC, you know, disseminated intravascular coagulation, where there may be a need. So our calculation is usually 1 unit per 5 kilogram body weight. So I don't know if that answers the question that
I can add
attendee
something
raised.
here. I can add something. Well, it will depend on the bag of the cryoprecipitate. It usually contains 100 to 150 milligrams of fibrinogen, and it depends what level of fibrinogen you want to accomplish, and according to the site of the bleed. And
Thank
whether
you.
you're using it during the active bleeds or during or as prophylaxis. So it will depend on the level that you want to attain.
There is also a question regarding the thrombotic phenotype, if we need to have a genetic sequencing for the patient, and what anticoagulant you advise along with fibrinogen replacement. I don't know who want to answer to this question.
If you want, I can answer. As we told before, it is important to have the genetic evaluation, especially for dysfibrinogenemia, because there are some type of dysfibrinogenemia that are strictly connected to a thrombotic phenotype. But it is also important to have the genetic profile also for afibrinogenemia, because as we told before, also especially the afibrinogenemia can have a very severe thrombotic phenotype. Moreover, as regard the anticoagulation that we can use with these defects, I think that until now the most used anticoagulants has been heparin, especially low molecular weight heparin. But now we can have also the direct oral anticoagulant that can be very useful now, especially also the anti-factor second A, cioè the antithrombin the direct oral anticoagulant. It is very difficult in these patients to use the classical anticoagulation with the warfarin also because if we talk about afibrinogenemia, they have either the prothrombin time and thromboplastin partial, the activity partial thromboplastin time that are not determinable. So it is quite impossible to monitor the INR. So I would say that the best for now, until now, has been the low molecular weight heparin, but now we have this other chance that I think that would be very interesting in these patients.
Thank you, Christina. Unfortunately, we have just the time for one last question, but we will answer to all the questions in the chat by email as soon as possible. The last question maybe is from Mike Macris to Philippe de Merloz. Do you think we will have a recombinant fibrinogen concentrate in the future? We discussed it before. And is the thrombotic risk due to the AFib itself or the concentrate treatment?
As concerning the recombinant, there was one paper, and we were hoping to see the following story about this recombinant, but we never saw anything. And if I can just add something, because it goes along with the question of gene therapy, there were several questions around gene therapy. Nothing really in the close future, I would say. The molecule is very complex. And there is, it's not like factor 9 or factor 8. And there was another question from Mike.
Yes, the thrombotic risk due to the afibrinogenemia itself or the concentrate treatment?
Yeah, it was partially responded by Suchitra. You all know that fibrinogen was called antithrombin 1, and it traps almost when you have an excess of thrombin generation, which is sometimes the case. And that's part of the explanation. And there are several other explanations from the people in the Netherlands and elsewhere. It's not very, very, very clear till now. And I think there are several explanations. And what we should not forget, I'm a little a proponent for that, is to do a thrombophilia screening in afibrinogen patients, because I think we can miss things, and it's so important for them. And when you do all the tests, to have just an idea about factor 5, factor 2, and things like that, I think it's part of the story in order to, when we supply the patients, to see the limit of what we do.
Thank you very much. So now we have to close this webinar. Again, we will answer to all the questions. There is many questions in the chat, very interesting. We will try to answer as soon as possible. Thank you very much for the participation.
Alessandro, just I really would like to thank the group here, because it was a great webinar and generated a lot of thinking questions. It's great to see 40 questions in the chat. It reminds me really of the early years of hemophilia, when people started to think about hemophilia and pose more questions and all that. And this is really, although it's not a new, let's say, disorder, but it's really putting the light now on it is really great things. And for the future, I would like to suggest to the group that you send us a diagram of the genetic transmission, diagram of the diagnosis, that we could also do some kind of printing in and sending to our Hemophilia Society and to the labs that they might be doing to help the diagnosis of this.
You mean a logarithm?
Yes, the algorithm of that's going to be very good.
Yes.
The one that you showed, because we need to put more let's say light on the distinction between hypofibrinogenemia, afibrinogenemia, and this, because you notice there was a lot of questions, people didn't get it quite well. So with that, it's going to be very good to put some more lights on it.
Sure.
And if you notice that we have 42 now questions, and we were not able to answer everything. So it might be good in the future to have some open forum also, and you have some kind of an email or something like this that people can ask and you respond.
Absolutely.
But if I can just say one word more, I think this webinar is a real success. And for me, the key things which is behind that is because we have Joanna and Christina. And with the testimony of two patients, it makes the things completely different. And I'm really grateful, Joanna and Christina.
Okay. So
Absolutely.
thanks to all of you.
Yes.
Thank you.
Thank you, Joanna
Thank
and
you.
Christina.
Thank you,
you.
everyone.
Thank you.
Thank you.
Sharing
Bye-bye.
your stories.
Thank you.
Thank you to everybody.
Thanks, everyone.
Bye.
Bye.
Good
Bye
night.
bye. Bye.
Night.
Bye. Bye.
Night.
Bye. Good night.
Bye.